Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation, on opportunities for Medicaid public health collaboration to achieve mutual prevention goals, lessons from CDC's 618 initiative. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 3 question and answer sessions during today's presentation. You may submit a question online anytime by clicking on the Q&A icon located on the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Maya Crawford, Senior Program Officer at the Center for Healthcare Strategies.
Great, thank you so much, Travis, and welcome everyone to today's Center for Healthcare Strategies webinar about CDC's 618 initiative. We will kick the webinar off with introductions and some opening remarks. I will then provide an overview of the CDC's 618 initiative and describe some of the noteworthy activities and accomplishments from participating states over the past 2 years. Next, representatives from Colorado and Nevada will describe their efforts under the 618 initiative to promote Medicaid public health collaboration and to accelerate adoption of evidence-based prevention strategies. And then finally, we will introduce you to a new CHCS website that houses a wide array of information, tools, and resources, all related to implementing CDC's 618 initiative, as well as describe a new 618 technical assistance opportunity for states and territories. So let's meet today's presenters. So starting us off with some introductory remarks will be Mishi Knight, Program Officer at the Robert Wood Johnson Foundation. Then after my presentation, I will turn things over to Colorado's 618 team. We'll hear from Michelle Lynch, Tobacco Cessation Supervisor at the Colorado Department of Public Health and Environment, and Richard Delaney, Policy Specialist at the Colorado Department of Healthcare Policy and Financing. Michelle and Richard will be followed by representatives from Nevada's Public Health Department and Medicaid Agency. We'll hear from Jenny Bonk, Chronic Disease Prevention and Health Promotion Section Manager in the Division of Public and Behavioral Health in Nevada's Department of Health and Human Services, and Aaron Lynch, Chief 3 for Hospital and Physician Services in the Division of Healthcare Financing and Policy, also in Nevada's Department of Health and Human Services. Finally, Alyssa Beers, Senior Program Officer at CHCS, will present about CHCS's 618 Initiative Implementation Resource Center. Now, before I turn things over to Mishi Knight, I just first wanted to say a few words about the Center for Healthcare Strategies. CHCS is a nonprofit health policy center that works to improve the health of low-income Americans by promoting innovations in publicly financed healthcare through 3 core priority areas: advancing delivery system and payment reform efforts, enhancing access to coverage and services to ensure that low-income Americans receive high-quality, cost-effective care, and integrating services for people with complex needs. With that, I am very pleased to introduce Mishi Knight from the Robert Wood Johnson Foundation to say a few words about the Foundation's support of CHCS's partnership with the CDC to advance implementation of the 618 initiative. So Mishi?
Thank you, Maya. Hello, everyone. I'm Mishi Knight. As Maya just said, I'm a program officer here at the Robert Wood Johnson Foundation. And I just want to be honest and say I'm very much a fangirl of this work and count myself lucky to be part of the team alongside you on this journey. So I'm really, really just honored to be here with you today. I must first stop and thank CHCS, CDC, ASTO, and the many partners who contribute to this work. Your partnership and tremendous leadership are appreciated. So what's our WJF's commitment to the 618 initiative and why? The CDC 618 initiative is an important part of our efforts to build a culture of health, enabling all in our diverse society to have the opportunity to lead healthier lives now and for generations to come. But more specifically, I'm going to share with you 5 key ways that the 618 initiative is helping us to wrestle with some tough issues plaguing health and healthcare in our country today. The CDC 618 initiative focuses on a set of prevalent and costly health issues. And Maya will say a lot more about that in her overview, so I'll just pause there. But that's one of the reasons why RWJF is continued to be interested in this work. The interventions are evidence-based. So both anecdotes and evidence are critical to advance the field. Yet without the evidence, it's harder to realize the full potential for impact, garner greater support, and scale widely. 618 helps us to move forward from making blind investments in prevention to a place where we actually have interventions backed by evidence of their effectiveness in addressing chronic conditions and lowering healthcare costs. Thirdly, it creates a unique and powerful opportunity for public health and healthcare to partner together toward a common goal, improved health and lower costs. It won't surprise you when I say that in many states, what we've learned is that Medicaid and public health don't often collaborate. 618 aims to change that. Public health brings the why, the evidence base to support the need for interventions, and Medicaid brings the how, the specific levers to implement those interventions. Today, more than ever, we see states as vigilant in their pursuit of health, and 618 is one way they're able to lean in. It's one of a variety of approaches where RWJF supports states to build relationships, use data, get and share lessons to improve the health of their population. And fifth, 618 is practical and specific, which makes it a great tactic implementing these interventions, but also an important strategy, the building block toward more connected systems. This in turn builds the capacity for doing even more together, because the skills and approaches and mindsets associated with it is a gateway to working on things like the social determinants of health. We here at RWJF are thrilled to be able to offer our support to this effort. With that, I want to say thanks again to all of you for participating today and for your continued work on advancing the 618 initiative. Maya, I'm going to pause there and kick things back over to you.
Excellent. Thank you so much, Mishi. It's really been a pleasure working with you on this effort. So I will now provide a high-level overview of CDC's 618 initiative, as well as some examples of what states have focused on and accomplished when using the 618 initiative framework. The CDC developed the 618 initiative to promote adoption by healthcare purchasers, payers, and providers of evidence-based interventions to improve health and control costs in 5 years or less. So the name 618 comes from this initial focus on 6 high-burden, high-cost health conditions and 18 evidence-based interventions. It's important to note, however, that CDC is engaged in an ongoing evidence review process just to make sure that the conditions and interventions reflect the most up-to-date health and cost evidence, which means that the number of conditions and the number of interventions, as well as some of the wording used within the interventions, can change over time. So the initiative has 2 core goals. One is to improve health and control healthcare costs. And the second is to establish sustainable links and partnerships between public health and the healthcare sector, purchasers, payers, and providers, to really work as partners in improving population health outcomes. So today's presentation focuses just on one lane of 618 initiative work, which is to engage state Medicaid agencies and their public health counterparts on implementing chosen 618 interventions. But of note, CDC is also working to promote 618 strategies with additional payers, including those in the private sector, as well as directly with healthcare providers. So the 6 in 618 represents the 6 initial health conditions, which are asthma, tobacco use, type 2 diabetes, unintended pregnancy, inappropriate antibiotic use, and high blood pressure. And these 6 conditions are selected because they met a number of criteria. So firstly, they affect large numbers of people. They are also associated with high healthcare costs. There's an evidence base available and in particular interventions to both either prevent or control these conditions in a relatively short time horizon. And finally, the evidence-based interventions can be implemented by different stakeholders within the healthcare sector, including purchasers, health plans, and providers. and actually at different levels as well, at the state level, at the health plan level, or community level, and at the provider or clinical level. So there are three key phases of implementing 618 interventions, which we highlight on this slide. So the first phase that we wanted to note was around payer coverage, and in the case of Medicaid public health teams, Medicaid coverage for a particular intervention. So this means that a Medicaid program adequately reimburses for a particular prevention service, and that Medicaid enrollees have barrier-free access to that program, service, or medication. So examples of promoting Medicaid coverage under the 618 initiative can include removing copays for tobacco cessation services, bundling payments for immediate postpartum long-acting reversible contraception insertion from other postpartum services, and reimbursing for asthma home visiting services or for self-measured blood pressure monitoring. And these coverage changes can be achieved at the state level through processes like applying for a state plan amendment in Medicaid, an 1115 waiver, or other legislative or regulatory processes, or at the health plan level, such as by incorporating new benefits language into a Medicaid managed care contract. The next phase is provider adoption. So assuming that there is adequate coverage for a service, this stage works to ensure that providers know about the covered benefit and work to provide access to a particular service or referral to that service. So there are many things that state level officials can do to promote provider adoption. So this could include educating providers about a coverage change, such as through a provider bulletin, or highlighting the importance of linking patients to prevention through things like fact sheets, posters, or webinars. Providers may also need some assistance around which billing codes to use for getting reimbursed for a service, or some additional guidance around how to refer patients to services like tobacco quit lines or to the National Diabetes Prevention Program. And then the final phase here is consumer utilization. So this is working to ensure that Medicaid enrollees are aware that they have access to prevention services or other programs, and often at little or no cost. So a number of the states that we've engaged under the 618 initiative have worked to boost consumer knowledge of available Medicaid tobacco cessation benefits. So using outreach strategies like billboard ads, radio ads, and targeted social media campaigns. And I'll actually hear from one state today, Colorado, which has led a successful effort to get the word out about their Medicaid tobacco cessation benefits. So why adopt CDC's 618 initiative? We highlight three core reasons here, and these are especially relevant for Medicaid programs, which may not know about the initiative and have a lot of competing priorities. But there are really clear benefits to taking on 618 related work. So the first reason we highlight here is that the 618 initiative aligns with quality improvement goals. So for example, 618 interventions may align really well with goals included in a state's quality strategy, which are used by states and their contracted health plans to both assess the quality of care that's being provided and to set measurable targets for improvement. 618 interventions could also help Medicaid health plans and their affiliated provider networks meet specified quality targets in their state contracts. So the second reason is around is the fact that the 618 initiative can help accelerate the impact of value-based payment reform, or VBP efforts at the state level. So we know that each 618 intervention has a strong evidence base for improving health outcomes and curbing cost growth. And that's exactly what value-based payment strategies also aim to do. So state officials should really work to think about opportunities to align 618 with their VBP objectives. So they could do this by incorporating prevention-related metrics into VBP arrangements, by incorporating population health priorities into managed care contracting incentives, such as quality withholds or incentive pools, and finally, by engaging providers in prevention activities under value-based payment delivery systems. So for example, in a patient-centered medical home context, using care coordination payments as a means to pay for prevention strategies. And then the final reason here for adopting the 618 initiative is to promote cross-sector and cross-agency collaboration. And CDC conducted a number of interviews with states who've received 618 initiative technical assistance and found that participation was really able to increase coordination between Medicaid and public health in many ways, opening up communications channels, promoting a better understanding of each agency, and enhancing resource sharing. This is a map of 618 participants who've received technical assistance from CHCS, CDC, and a number of other partners, thanks to funding from the Robert Wood Johnson Foundation. So far we've provided technical assistance to 15 states, the District of Columbia, and Los Angeles County. And we are now looking to expand this initiative to reach even more states, more payers, more providers, and to enhance adoption of 618 interventions across the country. My colleague Alyssa will talk a little bit more about opportunities to do that during her presentation. So here's some sample results associated with adopting CDC 618 initiative interventions. We've seen this in states who have adopted interventions prior to the launch of 618, and there are now some outcome data available suggesting cost savings or costs avoided as a result of adopting these interventions. So for example, Colorado, through its efforts to expand access to its family planning program and to provide Medicaid-enrolled women with low or no cost, long-acting reversible contraception, estimated avoiding over $66 million in costs over a 4-year period. And then some other noteworthy results from Rhode Island's asthma home visiting program saw significant reductions in asthma-related hospital and emergency department costs, as well as in Massachusetts, many savings associated with following the implementation of evidence-based Medicaid tobacco cessation benefits. So I'll now quickly highlight some notable accomplishments from the states that we've engaged over the past 2 years in 618 initiative technical assistance. So kicking things off with Maryland, who focused on preventing type 2 diabetes. So they are currently applying for an 1115 waiver amendment to actually build on a current demonstration project that they have to cover the National Diabetes Prevention Program through Medicaid managed care organizations. And they've engaged over 600 enrollees so far and have a lot of preliminary data suggesting significant weight loss. So they are now working to enhance access to the national DPP through electronic referrals and engagement of primary care physicians, and are working really purposely to align their efforts around type 2 diabetes prevention with other population health and value-based purchasing objectives. Next is Michigan, and they had some really nice accomplishments related to asthma control while participating in the 618 initiative. So they engaged with Medicaid leadership and Medicaid managed care organizations to ensure that Medicaid beneficiaries had access to spacers, and secured a commitment through their managed care plans to provide 4 spacers per year for each qualifying individual without prior authorization through the pharmacy. And it also worked to build on their successful MATCH program, which is an asthma home visiting program, and recently released a report showing really some significant results at 3 MATCH sites over the course of the past few years. Next is Minnesota. They focused on reducing tobacco use under the 618 initiative, and they worked to conduct a survey of their Medicaid managed care plans to better understand how Medicaid tobacco cessation benefits were being offered. As a result of that survey, saw some variation across plans, then worked directly with their health plans to standardize the benefits package and make sure that that was being appropriately articulated to Medicaid enrollees. They also did a lot of community-based outreach and communication about the benefit, and are now analyzing data from their all-payer claims database to establish some robust utilization data across payers about how Medicaid enrollees are using tobacco cessation services. And then finally, New York worked under 618 to prevent unintended pregnancies and made a couple notable coverage changes related to this. So they received a state plan amendment to allow federally qualified health centers to pay for the actual acquisition cost of a LARC device outside of the PPS encounter rate, as well as to require their Medicaid MCOs to pay hospitals separately for immediate postpartum insertion of LARC devices, separately from the inpatient stay. They've also done some really great work to engage providers as well as Medicaid enrollees themselves about available contraception. So with that, I will now turn things over to my colleagues in Colorado. So Michelle Lynch and Richard Delaney will be presenting about their work on tobacco cessation and what they've been able to accomplish by partnering on the 618 initiative. Okay, well, turn things over now to you all. Michelle and Richard.
Great, thanks so much, Maya. This is Michelle Lynch. I'm the Tobacco Cessation Supervisor in Colorado, and my role here is to oversee our cessation initiatives as well as our tobacco-focused health systems change work. And just really before we get started, wanted to give a big thank you to our partners at CDC, to CHCS, and of course the Robert Wood Johnson Foundation for both making this initiative possible. We're thrilled to have been a part of this for the past few years and also for the opportunity to share some highlights with you today. So to that, we'll move to the next slide, please. Great. So this slide is really just giving you a little bit of an overview of what we're going to cover today for our state. So Colorado has been engaged in a cross-agency, multi-pronged approach to, as Maya suggested, increasing coverage, provider adoption, and utilization of tobacco cessation benefits in our Medicaid population. And so this is just, again, a brief overview of some of the activities, the sectors of activities that we've been engaged in. Next slide, please. And on the next slide, I just want to highlight, and I know that this is not a dissimilar case for most of the nation, but on the next slide, I really wanted to highlight the disparity that we see in Colorado with our Medicaid population in terms of smoking prevalence. So these bubbles indicate, based on payer sectors, the relative prevalence of smoking. And so you see Medicaid population is 3 times that of our higher SVS Coloradans who are privately insured. Our state average is 15%. And then you see even there, the Medicare population distinctly lower than that of Medicaid. So we really identify in Colorado a real opportunity to focus on this population and to ensure that they had access to as many evidence-based tobacco cessation strategies as possible. Next slide, please. So the next section is really going to highlight this first kind of sector of work that we were engaged in, really around the idea that we had a fairly robust set of Medicaid benefits for treating tobacco dependence for Medicaid members. And so we really wanted to do 2 distinct pieces. We really wanted to work with providers to ensure that they were aware of the great benefits that we already had, but also to glean from them specifics around how we could both strengthen the benefit and work with them to communicate effectively their role and so that they could really optimize their use of the benefit. And so this is just a quick snapshot again of some of the key activities that we worked on. The first was to do a comprehensive knowledge assessment just to really understand the perceptions of providers around this benefit. What were the questions? What were they already using? And how could we support with any resources or education in helping to advance that? We also convened a multidisciplinary clinical advisory group, again, to help really inform. These were a group of already existing tobacco champions throughout the state. We partnered on a toolkit that, again, really highlighted best practices in terms of tobacco treatment, in terms of coding and billing practices for our cessation benefit. We also engaged in a multi-part webinar series that really focused on breaking topics and key topics that this multidisciplinary provider group identified as being really pertinent to their work. And then finally, we do, as an ongoing process, we engage local public health agencies in supporting this work at the local level. Next slide, please. I wanted to highlight some of the key, because we often get this question around how did you identify the webinar topics and what did those topics look like, and really what was that provider training and academic detailing piece centered around. And so this is, again, really just a high level kind of snapshot of some of the key topics that our provider community really identified as being pertinent for them. First, again, as I had mentioned, we did a robust review of the existing benefits and really did some tailored Q&A around how the providers could get the most out of that benefit. Second, we know, I think, again, nationally, we're really seeing a lot of trending towards wanting to provide more mobile and online-based support for tobacco cessation for our clients. And so we did have NCI came out and actually did a partner webinar around mobile health interventions. We always work very hard to cross-promote our state quit line, which does serve Medicaid members with a full service of coaching and FDA-approved medication. So also wanting to, again, kind of cross-pollinate that knowledge. And then lastly, we did a lot of work to really focus on our other priority populations, which we know there's a lot of intersectionality with the comorbidities with Medicaid members also having behavioral health challenges. We see a higher than average smoking prevalence with our Medicaid pregnant population. So really wanting to get some of those tailored tools and tailored intervention in the hands of the providers that serve these clients. And on the next slide, we'll talk a little bit more about the evaluation process. So this has really been a 3-year project for Colorado. And we've worked with very closely with a public health consulting group, John Snow Incorporated, who's been a tremendous partner to the state of Colorado in helping us really to create this work and to really roll it out. And JSI is actually conducting a very a multi-pronged and comprehensive evaluation of this provider-focused activity from this 3-year project period. And they're really looking in 4 key domains of reach, relevance, quality, and efficacy. And so I wanted to share a little bit of the interim evaluation report data. So from the initial reports that we have, 85% of the providers that attended the trainings did report that the quality of the webinars were excellent or good. And a full 90% of attendees stated that they acquired useful information that they would be able to translate into practice. Another key objective of the evaluation is really to determine, again, really how many of the participants would be able to take this information forward and actually change the way that they were practicing tobacco treatment in their clinical practice based on the knowledge that we provided or had supported them in learning both from JSI, from the state of Colorado Health Department, our partners at Medicaid, as well as really creating a forum where they could learn from each other in a peer forum. And of those, 53% indicated that the information learned would actually change the way that they would approach their clinical interventions for tobacco treatment. Next slide, please. So on our next slide, we're going to cover a bit of the work that we did to increase utilization among Medicaid members. I'm not sure if we're having a slight challenge with the forwarding piece. In the interest of time, I'll begin speaking about that. So in terms of our consumer outreach, again, we had a kind of multifactorial approach to this. We did use a mass media communications firm who had expertise in engaging lower socioeconomic demographics. And so for our consumer outreach piece, we primarily focused on a digital media campaign, knowing that the majority of Medicaid members do have a smartphone or a cell phone. We also worked with our federally qualified health centers throughout the state, and we really targeted the FQHCs throughout Colorado that we knew were serving a population with an even higher smoking prevalence than we see typically. So we know for Medicaid generally the smoking prevalence is higher, but there are certain pockets of the country and certain FQHCs that are serving areas that do have particularly high tobacco use burden. And so we focused on those FQs to provide them with a series of posters and other static print materials that they could use to both start conversation within their clinic settings, as well as to conduct some outreach. Next, we also focused on a terrestrial radio approach, where we actually used local clinicians who may have some notoriety or some be known in their communities, and we actually used their vocal talent to conduct some radio spots where, again, we were promoting the Medicaid tobacco cessation benefit. And then lastly, we engaged in, I think, an innovative approach to really look at where Medicaid members were engaging within their community, within faith-based organizations and other community-based organizations, and we conducted some actual grassroots outreach that way through partners. On our next slide, which unfortunately you can't see, but all of you will have these slides in hand. I know that they've been shared out. Our slogan, which we had done a formative scan of existing local and national campaigns to really inform campaign development, to again make sure that we were using an approach and using language that was familiar. Some of the commonalities that emerged when we were doing the initial review were that family, kind of the concept of family and the importance of family, was really a motivating factor for our Medicaid population. That positive and affirmative messages and images were also a motivating factor. We know that cost really is a challenge for many of our Medicaid members, as they do have fewer resources. So really thinking about how we could message that the Medicaid benefits were free or no cost. And of course, making sure that we were focusing on health literacy and using a plain language approach by implementing a simple and direct message. So our slogan for Medicaid, our Medicaid consumer campaign, was that quitting smoking is covered with Medicaid. And it used, again, a very simple and very approachable, we think, graphic that, again, when you see the slides, you'll be able to share that. And then now I'm going to turn it over to Richard to discuss the work that we actually did to increase access. As we know, reducing out-of-pocket cost is a key evidence-based action to ensuring that the Medicaid benefits that we do have are both accessible and utilized by Medicaid members. So I'm going to hand it over to Richard to talk a little bit about how we work to remove barriers to the benefit.
Thanks, Michelle. Thanks, Michelle. Can you guys hear me?
Yes.
Okay, good. We're on slide 32, expand. My name is Richard Delaney. I'm a policy specialist at Colorado Medicaid. I cover physician services, which includes preventive services and tobacco cessation counseling. If you move on to slide 33 for those with paper copies. Colorado added comprehensive counseling as a state plan benefit for all members in 2015. We adopted the U.S. Preventive Services Task Force A and B recommendations, which include comprehensive counseling. All Medicaid programs had to provide smoking cessation counseling to pregnant women, which Colorado did, but it was expanded in 2015. And with that expansion, we cover all 7 FDA-approved medications for tobacco cessation counseling, the prescription ones as well as the over-the-counter. A client could get 2 90-day courses of the prescriptions, and there's a PAR required for the second 90-day treatment, and if they went to any of the prescription medicines like Chantix or bupropion. So that was the current Colorado benefit. Moving on to slide 34. As part of this project, we listened to the health department and participated in some of their webinars and heard the information about the cost sharing, even though it was $1 or $2 at most for the prescription medicines. The cost sharing was removed for all the medications. There was never any cost sharing on the tobacco cessation counseling, the actual medical benefit. Before the prescription benefit, there was, that we made the decision late last year to remove the cost sharing, and that was removed for tobacco medications. Moving on to 35, slide 35. There's also a statewide pharmacy protocol in Colorado, which allows pharmacists to provide some medical services, such as prescribing over-the-counter medications. We're working on adding that, adding tobacco cessation items to the pharmacy protocol that we will adopt in Colorado. We're not there yet, but we're still adding. The home visiting nurse billing. This is going, for those of you Medicaid people who are on this call, you'll understand. The nurse home visitor program we had used to use a bundled payment model under targeted case management, but CMS informed us that that was no longer going to be appropriate, that the nurse home visitor was going to have to bill all their services done independently, which included tobacco cessation counseling for first-time mothers. And the way we were set up at the time was, if they used the comprehensive or the bundled code, the registered nurse could be the billing or rendering provider on it, and it would pay. But once they started having to separate out all the services, the registered nurse who does the nurse home visiting program would have to bill for that individually. And in Colorado at the time, we had a requirement that if the supervising provider, either an advanced practice nurse or a physician, had to be on site with the registered nurse. This was a holdout from when we created the program back in the 80s. But so there was going to be a big barrier to the nurse home visitor delivering tobacco cessation counseling and getting paid for it. They could always deliver, but in order to pay them for it, we changed our rules in the state administrative law process to allow registered nurses to deliver tobacco cessation counseling without on-site supervision. They just had to be in electronic supervision with their supervisor. So we made that change, you know, as a result of trying to expand the tobacco cessation program. And then moving on to slide 36. Did you want to do this one, Michelle?
Sure, I'm happy to. 1 second. Apologies for the slight delay here. So thanks, Richard, for covering kind of that provider type expansion, which we know, again, a key kind of barrier to, you know, many Medicaid members is that they often are living in medically underserved areas, or again, are only accessing services either when there's an acute condition or another need. So the ability to kind of have this cross-pollination where more specialists are trained in tobacco treatment and feel that they can, again, code and bill, we know has been really a key next step to ensuring that more people are being touched with these services. So moving on to the next piece, kind of looking at what we're seeing, because I know that really the key here is, are any of these actions really driving results? And that's something that we collectively across agencies are very interested in studying. So our initial results, when we're looking at counseling procedure codes that have been billed, as well as cessation pharmacy claims, we actually see over 2015, which we're really looking at as our baseline year before we started this comprehensive set of activity, we're seeing counseling rates increase 36% from 2015 to 2017. Similarly, cessation-specific pharmacy claims increasing 37%. So while, again, there's still work to be done in Colorado, we're very excited about these improvements in utilization rates. And on the next slide, just want to speak briefly about kind of what we're looking forward to on the horizon for Colorado around tobacco treatment, kind of expansion and continued work in this space. So one of the kind of key pieces that we've been really excited about in Colorado that we think has really enabled us to move a lot of this work forward, even beyond tobacco, but also in other chronic disease realms, has been the creation of interagency liaison positions. So we have staff dedicated at each agency to support streamlining and strengthening collaboration, both with alignment of priorities as well as communication. As you know, again, everyone on the phone, I'm sure, can appreciate that we all have just, our platters are overfull and we have a tremendous amount of competing priorities. And so really the creation of these liaison positions, which share population health expertise and public health expertise, kind of sitting in these dedicated spots in each of our agencies, it really has helped us to, again, really align and really identify some priorities where we can do some shared work. One of the key, I think, accomplishments of this shared position, of this dyad, has been to strengthen our interagency agreement, and a big component of that has been to support data sharing across agencies, which, again, looking at the previous slide, has allowed us to really start to look at evaluating the impacts of our collective efforts.
Yes, and this is Richard, and just to build on that, one of the difficulties in Colorado, our agencies are separate cabinet level agencies, and we're physically separate by a few miles. So it's not like we have much opportunity to interact. And having staff assigned at each agency, whereas if I have a question about something regarding public health, I can reach out to the person at Medicaid, and they will reach out to the person at the health department and identify who would be the best person to respond. So by the same token, over at public health, if they have a question, they can reach out to the person at Medicaid, who will then triage the question to the appropriate staff. Before we had these positions, there was a lot of cold calling between agencies, and it was difficult to make the right connections.
Thanks, Richard. That's a great add-on. And in terms of next steps here, I want to take kind of the two second bullets, and then I'm going to let Richard really speak to this ancillary care piece within off-campus hospital services and other opportunities to strengthen coding and billing procedures for tobacco treatment. But around what we're planning to do next with continuing to promote the cessation benefit and work towards a further barrier removal. We're excited to look at the evaluation that JSI is conducting for our 3-year period of work to really dig into if we can parse out specific activities, both around provider outreach as well as consumer engagement, that were particularly efficacious so that we can hopefully continue those activities and continue to build on them. So that is really the next plan, is to really, again, dig into that evaluation and see which things are kind of going to give the most bang for our buck so that we can look to the future to continue those. And Richard, did you want to speak to the billing
Sure.
piece?
And this really plays into the next slide, slide 40, with bringing the constant information that the tobacco cessation is a public health issue. As a payer, you know, I'm mostly concerned about what the codes are open, whether they're being used appropriately, how much we're paying for certain things. But there was an example recently, this is again getting into the technicalities of Medicaid and billing, but we have a number of providers that are with hospital affiliated practices, and they do their billing from what are called off-campus locations of hospitals. They don't bill out of a doctor's office. And we have a way to identify when on the claim when it comes from an off-campus location of a hospital. And as part of a different project, I had just requested data on claims from off-campus locations of hospitals, and I was analyzing them, doing some look at what they were billing for and how often they were billing for it. But because of this project, because we've been working with Michelle, Public Health, and the CDC and CHCS, I started looking specifically for the tobacco cessation in this data. It was there. It was way down at the bottom as far as utilization. It was just, it was amazing how little it was used, given that this provider treats about 20,000 patients a quarter, and there were like maybe 500 claims for tobacco cessation in this off-campus location. And I'm not quite sure what we're going to do with that, but it just highlights how working on this, working with public health has allowed me to look at the data from a public health perspective and simply not from a payer perspective. And then move on to slide 41. Yeah, again, this project has been really beneficial to Medicaid and public health in Colorado by bringing us together. And there's going to be continuing activities in this area. We're looking to move into some diabetes prevention efforts, and we're counting heavily on the public health department to support us in that area, and they've already been giving us great information on it. And with that, Michelle, do you have any last words?
No, thank you for taking us out there, Richard. I would just echo that piece. And again, thank you to CDC and to CHCS really for creating this platform that, again, for Colorado really has been beneficial beyond just the immediate policy restructuring improvements and successes. I think that we really have really learned from each other kind of this new shared language, if you will, and really looking forward to seeing what the future holds around expansion of that.
And 43 goes to questions. There's one question in the Q&A section. Have you seen any increase in the engagement of persons with mental illness and tobacco cessation? If so, any results? And in Colorado, Medicaid, we haven't. Our mental health services are provided through a managed care organization. We split out physical and mental health. And the mental health professionals, and in their managed care contract, there is, they do cover tobacco cessation counseling, but we didn't really work with that population specifically, and I haven't requested any data to find out if they are providing tobacco cessation, but it would be a whole different service line. And again, that's Medicaid talk, but the benefit is there. We just haven't run the data to see if there's been any improvement in that area.
And this is Michelle. Just piggyback, I would agree that it is kind of a separate line of work. We have actually seen a decrease in smoking prevalence among persons with behavioral health conditions, and I'm happy to follow up with CHCF to dig in more if the asker would like more information around that.
Excellent. Thank you so much, Michelle and Richard. Fantastic job getting through the presentation despite our technical difficulties. Apologize that we were not able to see slides for a few minutes there, but I believe those should be back up, and we sent along the link to the slide deck. So please review any slides that you may have missed after the webinar. So the slide up now is just directing folks who may have any questions for Richard and Michelle about their presentation. You can enter those through the Q&A icon on the taskbar. So if any folks have any more specific questions, we can ask those now, and there will be additional time at the end of the webinar for more questions. So one other question, Michelle and Richard, before we move on to our presentation from Nevada. I'm curious if you encountered any challenges engaging providers. Was there any resistance from providers or any other challenges that you faced? And if so, how did you overcome those in getting providers to adopt some of the prevention strategies that you highlighted in your presentation?
Sure, Maya, I'll take this one and then really encourage Richard if there's any feedback that he has received directly as well. From our end, I think it's a lot of commonalities that I'm sure, again, a lot of other states are seeing and hearing in terms of competing priorities, particularly in light of meaningful use and adopters of EHRs and the many updates and reporting burden around those pieces. I would say that the other piece that we really learned from our focus group, our Medicaid Smoking Cessation Resource Group, was really how imperative it is to have clearly outlined objectives and clearly outlined kind of asks, of that group. They're eager to be engaged, and they certainly are highly supportive of population health approaches, but there really needs to be a defined goal, and they need to feel like they're working towards something. So I would say that really was something that we learned and that helped us to keep folks engaged.
All right. Thank you so much, Michelle. With that, I think we will actually now turn to our presenters from Nevada. So we have Jenny Bonk and Aaron Lynch on the line from Nevada Public Health and Medicaid, respectively, and who will talk about their efforts under the 618 initiative to prevent type 2 diabetes. So Jenny, shall I hand things over to you?
Thank you, Maya. And good afternoon, good morning to the few people here on the West Coast. We've got a few more minutes in our morning, but thank you for joining us. Go ahead. Well, this is Jenny Bonk. I'm the Chronic Disease Section Manager at the Division of Public and Behavioral Health in Nevada. Aaron Lynch will be speaking to a few of the slides in a little bit, and she is a Chief over Hospital and Physician Services at Medicaid. Next slide, please. So in the spring of 2017, Nevada's Division of Public and Behavioral Health, in collaboration with Nevada Medicaid, applied to be part of the 618 initiative to work on diabetes prevention by expanding access to a lifestyle change program known as the National Diabetes Prevention Program. In Nevada of 2016, diabetes prevalence was 11.1% per the BRFSS data. And pre-diabetes is severely underreported here, with 90% of pre-diabetic adults unaware of their condition. And we knew we wanted to do something to address this serious issue, ultimately reducing the incidence of both diabetes and pre-diabetes. So in June of that year, we found out that we were selected as a second-round state, and our team headed to Atlanta for the kickoff meeting. Next slide, please. So at the kickoff meeting, we were engaged in what I would call a power session, and we had national experts to help us, and they were experts in diabetes and DPP implementation. Included the CDC, CMS, NACDD, SHADAC, which is the State Health Access Data Assistance Center. It was fantastic, and they had so much expertise that we took advantage of. And we used our time to develop our 618 action plan, and we decided on a list of objectives that we wanted to include in our process, and that includes refreshing our diabetes provider toolkit, plan a diabetes summit, redefine the activities of our diabetes coordinator, increase the number of DPP programs and participation in our state, engage stakeholders to find a means for DPP reimbursement, and to improve our diabetes data collection. Next slide, please. Okay, so during the time of this project, our diabetes coordinator retired, and so we completed this project without a fundamental person from our program. We went from the end of September to the beginning of June without this position being filled, and actually I think it was the beginning of May. And so we lost a large amount of institutional knowledge, and so it was a learning experience for all of us. So we expanded our 618 public health team to include our quality improvement manager, Dr. Christy Robusto, and she joined myself and Masako Berger, who's our health systems manager on this team for the public health side. Nevada Medicaid also transitioned during this time, and new members were assigned to that side of the team. So Erin Lynch, she's here today to speak. She's now part of the team, and Sherry Eggleston, she oversees the diabetes policy. And so it's been a great experience for our relationship building between public health and Nevada Medicaid. So in all of this transition, we discovered that we already had an electronic version of our toolkit, and we're just working on fine-tuning it. And so with the new application of the 1815 Cooperative Agreement, we're also changing away from that focus to our new activities and priorities to align with the objectives in that agreement. So next slide, please. So currently we have 7 DPP provider organizations in our state. We have 1 that is fully CDC recognized, and 6 are pending. And 13 organizations offer DPP. We also have 50 DPP lifestyle coaches in Nevada. And we've identified many more entities interested in becoming national DPP providers. As we drafted our 1815 application, we found that hospitals, FQHCs, senior programs at some of the universities, and other partners and clinics wanted to be DPP providers, or they're interested in looking into it. And so I would credit that to the STEM meeting that we held in February, and I'm going to speak more to that in a little bit. But it really helped us build the partnerships that we needed in order to increase the DPP. So it was a surprising consequence of that meeting. Next slide, please. So we had excellent synergy going into the 618 initiative. Nevada was due for its diabetes state engagement meeting with the NACDD, and we were able to leverage this and turn it into our diabetes summit that we wrote into our action plan. In the spring of 2017, okay, I'm going to step back. Yeah, we planned the meetings in September of 17, but prior to that, in the spring of 2017, we were awarded the Strengthening State Systems to Improve Diabetes Management and Outcomes demonstration project by ASTO, and that allowed us to draft our state diabetes action plan in the summer of 2017 through the technical assistance provided by ASTO. And so we didn't want to duplicate our efforts, and so instead of turning the STEM meeting, the state engagement meeting, into our action plan meeting, we actually made it an implementation plan meeting for diabetes prevention programs. So in early February, we brought together approximately 65 diabetes stakeholders for the first day, and about 30 stakeholders for the second day. Day 1 included presentations on Nevada's diabetes and prediabetes status, as well as information on the national DPP, which many attendees, they were not familiar with that. And I just have to say that the technical assistance that we were provided by the NACDD team was exceptional, and it put together a very successful meeting. Day 2, we broke it into 4 groups. We decided on awareness, availability, screen test and referral, and coverage. And each group developed its own plans for moving these initiatives forward in our state. And for example, I was in the coverage group, and we used our time to share DPP coverage toolkit on the website, and we were able to engage both Medicaid and private payers in this discussion on how to move forward and try to get some coverage for DPP. We also had many new partners that are now interested, and this is kind of where that synergy came into play. Many more partners are interested in learning about DPP and becoming DPP providers, and it really enhances the 1815 Cooperative Agreement application that we put together as well. And the feedback we received on the STEM meeting was tremendous. People would tell us it was the best state meeting they had ever been to, very successful, and I really want to thank the NACDD for their assistance and expertise in helping us put that together. Next slide, please. So as I mentioned earlier, we lost our diabetes coordinator at a critical time in the project, which was a challenge, but it was also an opportunity. And so over the past couple of years, the Nevada Department of Health and Human Services put together a nutrition team. And they have co-located our obesity program and school health, the Office of Food Security, the WIC program, and the SNAP Ed program. And they're all located in the same office space. And so we have plans for this diabetes coordinator to become engaged with this group and enhance nutrition teams collaboration. And this position is also responsible now for ensuring that we have follow through for the diabetes action plan that we developed, as well as the DPP implementation plan. And so we will be re-engaging those groups very soon. Next slide, please. Okay, so at the same time, we wanted to improve our diabetes data. And at the same time this was going on, the Nevada Department of Health and Human Services actually formed their own centralized multi-agency data team. I think it began in late fall, early winter this past year. It also includes Medicaid on that team. And they, through that, have developed a data analytics work group. And so what this work group will do is look at multiple chronic diseases in terms of cost effectiveness and ongoing prevention efforts. The first condition that they selected is diabetes, and so that really works out well for us. And they have asked our quality improvement manager, Dr. Christy Robusto, to serve on this work group for our section. So we'll be getting some interesting new data pulled out on diabetes, and hopefully it will definitely clear up some of our communications with Medicaid, and we'll be able to fully understand the true burden that it has on our state. Okay, for the next slides, I'm going to turn it over to Erin Lynch from Nevada Medicaid. And I just wanted to add that we've really enjoyed building our relationship with Nevada Medicaid, and we're going to continue to focus our efforts, continued communication, data sharing, potential pilot projects, with our ultimate goal being a state plan amendment for DPP coverage. Go ahead, Erin.
Erin, if you're speaking, we can't hear you. I know maybe if you're on mute. Okay, maybe Erin is not able to join at this time. So Jenny, I don't know if maybe you just want to walk through the slides on.
Absolutely. Yeah, I will be happy to take care of it. So,
Lynch, are you able to hear me now?
Oh, there she is.
Oh, absolutely. Okay. Yes, perfect. Go ahead, Erin.
So sorry. Good morning, good afternoon. This is Erin Lynch. I am the chief over at Nevada Medicaid. I'm a chief over hospital and physician services, which also includes diabetes. So it has been a really great opportunity working with the Division of Public and Behavioral Health on this diabetes project. I previously used to work over there, so it was really great to get to rework with a lot of my colleagues over there and on building relationships with Nevada Medicaid. And so moving forward into this project, and I also started late into this project, so coming in kind of in the middle of it and trying to understand the project and next steps. So it was another great opportunity for us to build further. So one of our first items that we needed to participate in was the STEM conference, and that, like Jenny had said, it was February 6th and 7th. And so part of our task out of that summit was for us to write a budget concept paper and to move forward with how we would try and get the DPP covered with Nevada Medicaid. So we did write our budget concept paper, but out of that entire process, because there's a lot of reviews outside of my area, and it was determined that DPP wasn't going to move forward, so it wouldn't be covered in our next biennium budget, and so therefore we didn't have any budget authority to have DPP be a covered service. So, and I'm going to get into kind of some reasons behind that as well on some other slides. But we are looking at some other opportunities to further integrate DPP into Medicaid. For example, there's a pilot project. We're trying to get community health workers to be a reimbursable provider type, and maybe they could also be able to teach DPP classes. So that's just another example of how we're trying to still find other solutions and other creative ways to try and move forward. Next slide, please. Okay, so one of the reasons why DPP isn't covered with Nevada Medicaid is because we already cover like services with Nevada Medicaid. For example, medical nutrition therapy. So we have a brand new policy. It just was implemented January 1st, 2018 for medical nutrition therapy, and we would consider that a like service. So medical nutrition therapy, it's considered medically necessary for those who have diabetes, obesity, heart disease, or hypertension. It is prescribed by a physician assistant, or a APRN, and then it is actually provided by a registered dietitian. So medical nutrition therapy here in Nevada includes a initial nutrition and lifestyle assessment, one-on-one or group nutrition counseling, follow-up intervention visits to monitor the progress in managing their diet, reassessments as necessary to assure compliance with dietary plan, and also we have to see the results of medical nutrition therapy before these other like services can be implemented. So that's just like a brief summary of what the policy is. It goes into a lot more detail within our Medicaid services manual, but this is just a really good synopsis of what this covered service does provide. I think somehow a slide got skipped, unless it's next slide. Can you go back a couple? One more. There it is. That got skipped. Nope, next. There we go. Okay, so that slide got skipped. So diabetes data, I did want to get into just how we are collaborating with the Division of Public and Behavioral Health and Nevada Medicaid on being able to better understand our data. And Jenny gave some really good examples from our data analytics team with the Department of Health and Human Services. But we are also working with our fee-for-service vendor of Nevada Medicaid on being able to analyze diabetes data and finding where is it that we can make some impacts, or where is it that it's really a high cost to Nevada. So their clinical staff with our fee-for-service vendor have done a really great job at creating a clinical report for us, really analyzing the fee-for-service side on diabetes type 1 and 2. So in this report, they've also used data from CDC with the BRSSS and claims data. So it's just been really helpful for us to collaborate together and look at some other data that our fee-for-service side really has a lot of expertise in, and being able to find some correlations there. So it's just been another really great opportunity in using all of the resources that we have to partner together and see where it is that we can move forward on coverage. But right now, as it stands with our medical nutrition therapy, we want to see how well that coverage or that coverage service is going to assist our Nevada Medicaid recipients, whether they're on the fee-for-service side or whether they're on one of our MCOs. So that's all I have on my slides. I don't know whether we wanted to open it up for any questions or what the next steps were here with the presentation.
Yes, thanks so much, Erin and Jenny as well for your presentation. We have time for maybe one or two questions, and we did see one question already come in. So the question is, are the diabetes prevention programs for children and adolescents as well as adults, and are you finding that the interventions work across age groups?
So on the Medicaid side, medical nutrition therapy is for all age groups. And because it was just implemented January 1st, 2018, that does not give us enough time to even assess data because providers have up to 6 months to submit claims. So there's a claims lag. So So we don't have any data yet.
Thank you. And then one other question we have, and we're curious if you have any plans or strategies specifically for implementing the national DPP in rural areas of the state. And if so, how are you addressing challenges potentially related to reaching rural populations?
Hi, this is Jenny Baum. I would like to address that. We do have partners in our rural areas that are trying to implement this, and they actually have classes going on right now for DSME, or diabetes self-management education. And in order to address it, they couldn't meet the numbers that were required, and so they found a creative way to do it, and they got approval from from DSME founder Kate Lorig to do this, and they implemented a telehealth version of it. So they've got actually, or teleconferencing, I suppose. So they've got two rural locations with a instructor at both locations, but yet they meet that number, and by having, you know, a group in two different locations, they add those numbers together, and they have enough people to complete that class. And that's been very effective in those areas, because that could be a problem, is just finding enough individuals who are participating in the program. I think that we can certainly use that to apply to DPP down the road. And so we'll just have to see what the numbers look like and the participation and the completion rates look like. But we do have some other rural areas that are interested in becoming DPP providers, and we would probably do a similar process with that.
Great, thank you. And then one other question that just came in, and this one is asking about whether the National Diabetes Prevention Program is being introduced to the GDM postpartum client.
This is Jenny. I don't know if I know the answer to that question. I've been texting my health systems manager, because she knows much more about this than I do, and she says it's usually held for people who are 20 and older, and so our target population for DPP is adults. I would think that that would include postpartum clients. I'm not sure, you know, you've got to meet the criteria for obesity to be included in DPP, but so I don't know that it's been promoted to that group, but I think that's a very good idea. And also, I see some other questions about DPP. Nevada Medicaid does not currently reimburse for national DPP. They'll reimburse for the medical nutrition therapy that Lynch just mentioned, and they reimburse for DSME, diabetes self-management education. But we're just in a process of learning with them and communicating. So it is definitely a goal down the road, but it's not currently reimbursed.
Hi, this is Masako. I'm the health systems manager. Can everyone hear me?
Yes, again.
Oh, perfect. I couldn't talk earlier, so I'm glad. But just to address about the gestational diabetes part, given that Nevada is working on creating the nutrition unit, there could be a potential collaboration in the future with WIC offices targeting WIC participants to provide a WIC version of DPP. So we have been having a conversation with the WIC office. So we'll see how it goes.
Great, thank you so much. Okay, so we are now going to move to the next portion of the webinar. So I am going to hand things over to my colleague, Alyssa Beers, who is a Senior Program Officer here at the Center for Healthcare Strategies. And she will introduce us all to CHCS's brand new resource center for implementing CDC 618 initiatives, and then provide some information about a new technical assistance opportunity for states and territories to get involved in the 618 initiative. Great, so Alyssa.
Thanks so much, Maya, and thanks so much everyone for participating in today's webinar. We really appreciate your time and are very excited to share with you a new online resource center for supporting the work of the CDC's 618 initiative. So on today's webinar so far, you've heard two really great concrete examples of Medicaid and public health teams partnering together to implement CDC's 618 interventions in their respective states. And so I'm pleased now to take just a few minutes to highlight the new online resource center website launched earlier this month that is intended to provide some practical support and resources to further accelerate the adoption of these prevention strategies to continue to support states in terms of uptake on these interventions, in the same vein as you've heard in terms of the successes and achievements noted on today's webinar. So CHCS's online resource center is something that was supported with, was developed with support from the Robert Wood Johnson Foundation and also in close collaboration with the CDC and other partners. And so this is really an online compendium that offers both practical action steps as well as how-to materials to help state partners collaboratively design and launch proven 618 prevention interventions. So these include what you see on the screen here, both planning and implementation resources, health condition-specific resources, as well as an interactive map of 618 activities. And on the next few slides, I'll provide just a glimpse into some of these various components of the Resource Center at a high level. Next slide, please. So the site houses an array of resources, including a particular emphasis on highlighting states' activities, the health conditions and interventions that they've opted to focus on, as well as accomplishments. And all of this is with the goal of enabling states to learn from one another's experiences. We've heard many times that states are really interested in learning about what other states are focusing on and what their challenges and successes have been, so as to not recreate the wheel. To that end, the Resource Center comprises an ever-evolving interactive map to learn about evidence-based prevention interventions as well as accomplishments that align with the 618 goals. In addition, I will note that we welcome states outside of the formal 618 cohorts to share information and updates to us for inclusion on this map. In addition, the website features a series of brief two-page profiles which showcase how select state Medicaid and public health agencies are using the CDC's 618 initiative to adopt evidence-based prevention efforts. So each profile outlines select state activities as well as accomplishments under 618 to provide individuals with a really concrete look at what state Medicaid and public health partnerships can achieve. We do plan to include additional state profiles as this work progresses to highlight others' efforts. Next slide, please. There are a number of planning and implementation focused resources that are available on the site to help support new teams with getting started. These include TA resources that were developed during the first two cohorts of the initiative, as well as webinars, briefs, fact sheets, toolkits, and other informational resources, all to help guide states through the planning and implementation process. These resources are organized both by key categories to ensure that the materials are easy to find and accessible, such as resources related to making the business case, or resources devoted to delivering prevention-oriented care through partnerships, or payment and reimbursement strategies for prevention activities, and other key categories, as well as organized by stakeholder groups so that individuals can quickly explore the resources that are most relevant to their role in implementing prevention interventions. In addition, the site features a guide on getting started with the CDC's 618 initiative that was developed by the Association for State and Territorial Health Officials. Next slide, please. I want to just take a moment to highlight ASCO's Getting Started Guide in particular, as it helps state Medicaid and public health agencies determine how to form a 618 team if interested. And so this guide includes an information gathering tool to assist teams to identify and collect information relevant to their state on things such as leadership awareness and support, alignment with state health trends and priorities, covered benefits and utilization, policy changes, stakeholder engagement, and other categories. And each of those components includes a tips section with links to additional resources to help guide those state teams to additional information. So this particular tool is available through the CHCS 618 Resource Center as well as on ASCO's website. Next slide, please. And finally, the Resource Center also provides access to an array of condition-specific resources to help build the case for pursuing 618 interventions, as well as to guide implementation. And so this includes the CDC evidence summaries for each of the 6 high-burden, high-cost health conditions. Next slide. So here's the URL to the website. Please note that this resource center will continue to evolve, both with new tools and resources, as well as with the goal of eventually incorporating a shared interactive workspace component with features to support cross-sector alignment and collaboration. And so we hope that you explore the online resource center website, and we also encourage you to subscribe to receive email updates regarding new resources and opportunities to participate. Next slide. And finally, as Maya had mentioned, we wanted to share the upcoming 618 Initiative Technical Assistance Opportunity for the next cycle of support. And so coming soon to you next month, we will be providing information for Medicaid and public health teams to express interest in joining a new technical assistance opportunity that would run from October 2018 through October 2019. So one full year, 12-month cycle of technical assistance and support for implementation around a 618 health condition and related interventions. And so we do plan to send a statement of interest form to both state Medicaid and public health departments in July, and we'll then plan to kick off a formal launch of this cycle of technical assistance in October with an in-person convening. So more information to come about this opportunity next month, and we do encourage folks to subscribe to the 618 Resource Center email update to get more information that will come to you next month. And I will stop there and turn it back to Maya and see if there's any questions from folks on the line.
Excellent. Thank you so much, Alyssa. So if folks do have questions, we will now open it up for questions either on Alyssa's presentation, or if you have any questions about the previous presentations we heard from the Colorado Medicaid and Public Health team and the Nevada team as well. Open to all questions right now by clicking the Q&A icon on the toolbar, either at the bottom or the top of your screen. Okay, so to kick things off, I'll start with a question for Alyssa. So Alyssa, so people are listening today and they have tools or resources to contribute to the Resource Center, but maybe weren't a formal participant in past TA cycles. Are they still able to share a resource that may be relevant?
Sure. So that's actually a great question, and I apologize for not pointing that out explicitly. We are absolutely open to obtaining new resources and state-specific tools relevant to the 618 initiative and its goals. So if folks do have tools that they feel would benefit other states as they embark on implementation around these high-burden, high-cost health conditions or specific interventions, we would absolutely welcome those materials. There is a unique web email address that folks can feel free to email those types of tools and resources to us directly, and it is 618@chcs.org. So it's just the numbers 618@chcs.org, and then we can work with you to get those posted and approved.
Great, thank you so much. I also wanted to note at this time that we have our colleagues from CDC joining us as well and are on the line to answer any questions. So Dr. Laura Seif, who's the Director of Health Systems Collaboration in the Office of the Associate Director for Policy, is on, and she runs the 618 initiative at CDC, as well as Dr. Krista Singleton, who's Senior Medical Advisor in the Office of Health Systems Collaboration, and Heather Hastings, who's a Policy Analyst in that office. So welcome to all of you. And we have actually a question that I think would be best suited for one of our CDC colleagues to answer that just came in. And the question is, to what extent have private insurance companies been reinforcing or engaged in the Medicaid public health collaborations?
Hi, Maya. Thanks. It's Laura. Thanks for that question. And just a quick thank you to everybody at CHCS and RWJ and to all participating states and to Colorado and Nevada for your fabulous presentations and all the work. My answer to your question is the commercial insurers who also have Medicaid managed care contracts are participating typically inside of the state as the contractor to Medicaid. So, you know, a couple examples come to mind. Georgia, for instance, has 5 what they call them CMOs, not MCOs, but they were able to get all of their CMOs to line up together around coverage changes. And we're seeing that happen a lot in states. We are also, as you mentioned earlier, interfacing with commercial health plans across their other books of business. But in the space of Medicaid, they are reinforcing, but they tend to come in their relationship, in their contracted relationship with a Medicaid agency, which I think is appropriate.
Thank you, Laura. Okay, so we will go back to the online questions being submitted. We had a question come in asking how many state Medicaid programs reimburse for home-based asthma interventions. And that is a great question. I do not know the answer offhand. I'm wondering, do any folks from CDC have a sense for that?
I'm worried that currently the answer is very few. We know that, you know, Rhode Island is working to get coverage, as are a few other states, but I think, I don't even know if any have gotten Medicaid to cover a full home-based asthma control program yet.
Yep. Yeah, I know certain states in particular are really working to engage their Medicaid managed care plans on that. So that's certainly one route towards reimbursement. But we can follow up with some additional information to the individuals who asked that question to see if we can provide a little more concrete data about that. Okay, so the next question that we have coming in asks, how do you see the 618 initiative integrating with our current NCD consortium, also diabetes and cancer control coalitions? And says, we are currently looking at the WHO SDG initiative and adopted the US PTF guidelines. So I was just curious how the 618 initiative might align with some of those other efforts.
Maya, do you want me to take that?
Yeah, Laura, why don't you take that one?
So I guess broadly speaking, I would say that as we look to expand 618, so we've been really pleased to see both the strengthening partnerships across sector and then the use of very discrete interventions to make cost and health improvements. And given the really wonderful successes as you know, and as you've heard from Maya and Alyssa, we're looking to expand this ultimately to be able to assist, in the future, any state that wants to participate. As we look to expand, which is what we're facing this summer, we're looking for every opportunity to integrate with other existing chronic or infectious disease programs where relevant. So for those of you who are grantees of our SME programs that are also participating in 618, we're looking for ways to weave together what you do on a day-to-day basis with your project officers in those programs and what you would do with 618. And ultimately, we hope that that would look seamless to you, that we're all integrating the support. In as much as this also could be integrated into a larger chronic disease plan, I would say, I would encourage that. And if there are ways that CDC can help you do that, we're happy to think about it. But at the end of the day, we'd like both the approach and the content of 618 to be woven into what you're already doing and then provide a foundation for you to do that same kind of work without it looking like you've got multiple kind of disaggregated efforts. I don't know if that's specifically answering your question, but broadly speaking, we'd encourage that sort of integration.
Absolutely. Thank you, Laura. So another question came in asking if we would be open to a Medicaid oral health collaboration through this initiative. So Laura, any thoughts on that?
Sorry, Maya. So we were quite disciplined in how we defined the content in 618, sometimes frustratingly, but I think it's been helpful. And so where we wanted this sort of Venn diagram of collaboration between public health and the healthcare system was where we knew, and you heard Maya really beautifully go through the criteria at the beginning, you know, where there are high burden conditions that are high burden because of prevalence and cost, they are preventable or controllable. The things that we know that prevent or control them both improve both health outcomes and cost outcomes quickly, less than 5 years. And so that's where we start to get, the list gets very low when we get to things that work quickly. And the interventions that we know work are being either are inconsistently covered by insurers or are covered, you heard a nice example from Colorado, but aren't being utilized as much for various reasons. So, and you also heard Maya say that we're keeping a regular finger on the pulse of the evidence. And so we're looking to add more interventions and more content areas, but we'd like to keep those criteria in place. The other kind of unintended benefit of using those criteria and keeping the list small is it keeps us from bringing 100 topics to an insurer or health system. It keeps us really focused on a short list of things that we know work. Having said all that, there potentially are things in the oral health bucket that could fit. We did a pass last year and there weren't any that fit exactly those criteria, but we're certainly always open. And if you have particular things within oral health that whoever that questioner was that you want us to take a look at the data, we can do that. And let me just say one other thing, Maya. We have been asked by internal and external partners about how we can use the 618 platform to highlight other effective interventions, but that don't fit those criteria. And we're thinking hard about that, because if the platform itself is useful in bringing together partners on broader issues, we'd like to all think creatively about how to do that.
Great.
So back to you, Maya.
Thank you so much, Laura. Appreciate it. Okay, so with that, we are now at the conclusion of our webinar. So I encourage you to visit the 618 Resource Center and the CHCS website and to fill out the survey at the very end to help us improve our webinars and to get more information about what you would be interested in hearing more about related to the 618 initiative. So I would like to thank all of our speakers and presenters from today. Thanks to Mishi Knight and to the Robert Wood Johnson Foundation, to our presenters from Colorado and Nevada, our partners at CDC, and the other organizations we work with to provide technical assistance to 618 teams. So I will close the webinar there. Hope you all have a great afternoon and look forward to engaging with you further around the 618 initiative. Bye-bye.